Hello everyone, and welcome to CK Med. My name is Clark, and I'll be taking you through cranial nerve 5, trigeminal nerve today. Now, cranial nerve number 5 is a beast. It's one of the biggest nerves, if not the biggest nerve, in the skull, that as far as cranial nerves go. And so why this is important is to understand, first off, just the bare bones aspect to it and its purpose, but also a little bit more fine details and how we can break up each of the different branches. And so first thing you want to understand is the purpose of the trigeminal nerve. So the purpose of the trigeminal nerve is to carry out a few functions. Sensory for the entire face, except for the angle of the jaw, and motor for a few muscles, which we'll be discussing today. So first things first, we want to understand where exactly are each of these branches going for sensory. And so this Utah resource, I will be posting this in the comments below, and it also is located on our Facebook page. So please feel free to check that out, and you can download any of the files that I also post following this video. I will be doing a neuroanatomy video after this, so definitely check that out as well. To help you out with your exams. So for this, the first branch, known as the V1, and V is really just the Roman numeral 5, which is cranial nerve number 5, but we decide to make it easy by saying V because it looks like a V. So your V1 is your ophthalmic nerve. So definitely understand its basic function is V1 is only sensory. And it's nice because what does it do sensory from? It's going to be from the apex of your head, the top of your head, over your scalp, all the way down to the tip of your nose. It doesn't do the sides of your nose, and it does your upper eyelid, not your lower eyelid, just your upper eyelid. And so that's just kind of like the general understanding. And there's going to be different named nerves here, and they kind of describe exactly where they're going. And I'll give you a few tricks, especially for your lab when it comes down to a few of these nerves. So that's going to be your ophthalmic nerve. How it comes off your trigeminal ganglion, which is where the cell body fibers are, your postganglionic, right? So your postganglionic nerve sensory fibers, which is this dark blue, is just general sensory for like touch, vibration, and proprioception, are going to travel up, and they are one of the nerves that travels through the cavernous sinus. So keep that in mind. That is a possibility. But remember last time we discussed how cranial nerve number 6 is most likely hurt if we have a aneurysm in the ophthalmic artery or internal carotid, because internal carotid passes through the cavernous sinus and abducens nerve is right next to it. So that's where you're going to get damage here. You're not going to be able to laterally move your eye, whatever side, left or right, depending on what side you have this aneurysm. So your ophthalmic nerve passes through, or V1 branch, passes through the cavernous sinus and exits the skull behind the eye through the superior orbital fissure, which is this big guy right here. This is one of the nerves. We have several that go through here. And this comes out and it gives off a few kind of major-like branches. And we want to understand these ones because this is something that they can easily tag in lab. Someone has dissected these specimens very well, and so they're very taggable. Now these tiny miniature ones, no. But these three, absolutely. Think that one of them is going to be on your lab practical. But it's kind of important to know where these are going. And so when we're looking at this whole area, this whole entire person's face, we're looking at it from a lateral side. Therefore, this nerve, which looks behind these other ones right here, means it's towards the nose. And so it's really describing where it's going to go. So it's going to give off branches for your eye, ciliary, and it's going to go towards your nose. So this is more medial. And so when you see these three little branches and you're going, oh shoot, is it nasociliary, is it frontal, is it lacrimal? Just know this, the one that's going medial is your nasociliar. The one that goes right over the eye, directly on top of the eye, like right over the middle of the ball. So if we looked at it here, it would be going straight over the top. That's going to be your frontal nerve. It's not going to be medial, it's not going to be lateral, it's going to be right over the top of your eye and come out of the skull. That's your frontal nerve. And then the one that goes more laterally, and this is a key one, this is one they really like tagging, is your lacrimal nerve. So 1, 2, and then 3 is going to be your lateral, which is lacrimal, L for lateral, in that lacrimal, goes to your lacrimal gland, because where's your lacrimal gland? Oh, it's the lateral part of your eye. So keep that in mind for when you're going into wet lab. Some important structures here that are involving some of your parasympathetics, which hop off of cranial nerve number 3, are going to be really your ciliary, because trigeminal gives off this kind of ganglion. It kind of puts in the fibers so that these different nerves can come in and synapse here. Although they're kind of separate, they're just going to be doing your parasympathetics. Just remember that the main branch comes off your trigeminal. They probably won't test that, but that's just a side note. Also, your autonomics for your sympathetics, which is your fight or flight, comes in on your long ciliary, and that's hopping on to trigeminal V1 branch. So if they were to say, oh, sympathetics going to your upper eyelid or something like that, kind of went out. What part of trigeminal or what nerve does this travel along with? It's first off, you're thinking long ciliary, but if they want to be more broad, they'll say, oh, a branch off of your V1 or ophthalmic or trigeminal nerve. So that's going to be all describing this guy right here, long ciliary nerve. And that's just for your autonomics on your sympathetics. Because remember, your parasympathetics, P goes with S. S does not go with S here. P goes with S. So parasympathetics go on short ciliary, sympathetics on long ciliary. So those are your 3. All these little branches here are really insignificant other than just your basic understanding. And so for your V1 branch, you want to talk about just general sensory. So if you're going to say, what's the sensory of your cornea? That's going to be traveling back for your V1 branch. Simple as that. Cornea, or you're stabbing your eye, that's V1 branch. Anything above your eye and where that sensory, which we pulled up here, remember this? All these little branches are going to just describe where they're going. So if you're saying these posterior ethmoid, anterior ethmoid, all these ethmoids go into your ethmoid sinus. And where's your ethmoid sinus? That's behind your nose, right? In your ethmoid bone, which is where cranial nerve number 1, your olfactory nerve, enters in to pick up smell, right? So these are traveling medial into your nose, is pretty much what these ethmoids are. Your trochlear means it's over your trochlea. And where's your trochlea? That's medial. That's just to the medial and upper side of your eye. So like if you were to poke the middle part of your eye where you have your tear duct and then push upward a little bit, that's where your trochlea is. And so that's where this nerve goes. And so it does sensory right there. This is simple. All these little branches are just doing general sensory. So if I got stabbed in any one of these places, you're going to pick one of these. However, they're really not going to be that particular because that's really messed up. Because these little tiny fibers do a tiny, 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 tiny little area on your skin. Really, they're going to give you a choice of, okay, this person got stabbed above the eye. Is it the supratrochlear? Is it the zygomatic orbital? Is it the infraorbital? Is it the lingual nerve? So obviously you're going, okay, it's above the eye. It can't be infraorbital, which is below the eye. Can't be any of these other ones. So simply, nice, we're going to do that trochlear, which is above the eye, okay? So those are simple sensories there. Remember, your lacrimal, frontal, nasociliary are your main branches, lateral, right over the eye, medial, and those are doing, again, general sensory. So touch, vibration, proprioception. So that's nice and easy. That's your V1 branch. So now we get a little bit crazy when we're talking about our V2 branch. So V2 is your maxillary nerve, which is nice because it goes right to your maxilla, where is your maxilla? It's right on your face. And if you look at this, what do you know of face? And so we have our V2 branch, or our 5-2, if you want to think of it trigeminal. It's cranial nerve number 5. And this does sensory on really the side of the face, the side of the nose, your lower eyelid, and your upper lip. That's really where you're wanting to think that this guy goes, okay? That's really what you're wanting to go into far detail. If you want to go a little bit more detail, just think of it as your inner nasal cavity, So if someone stabs something up their nose and it hurts really bad, you're thinking of V2 branch, okay? So your maxillary nerve. And that also does sensory of your palate, and again, your upper lip. So remember that. So let's go and talk about this general sensory. So again, vibration, the general sensory like touch and proprioception are all carried on this guy. Remember, the ganglion cell bodies are going to be back here in trigeminal nerve ganglion. So here we are, maxillary nerve. enters out, or goes through, this is another nerve that goes through the cavernous sinus. So remember that. V1 and V2 travel through the cavernous sinus. However, it doesn't go out via the superior orbital fissure. It goes through its own little exit point. This is your foramen rotundum. So let me pull this up and you can see this. It's not a super great picture, but it's just this oval, or a round one, I'm sorry. It's not oval, it's round. This is foramen ovale, this is foramen rotundum. So it's a little bit more anterior, which is nice because it's really going directly straight out towards where your maxillary bones are. So it's nice how the anatomy is set up here. So most importantly, just remember that this does the top of your nasopharynx sensory. It does your palate. It does your upper lip. It does your upper teeth. It does the sides of your nose and your cheekbone. Okay, so that's very important. So your zygomaticotemporal, anything zygomatic nerve, anything describing that is really going to be your sensory. But also remember that we have some parasympathetic or autonomic fibers that go via zygomatic. You have to shortcut through the neighborhood to get up to your eye. So that's also important. But check out our other video. This is cranial nerve number 7. I'm going to actually take that off right now. Cranial nerve number 7 is that guy. So cranial nerve 5V2 is important for carrying fibers from cranial nerve number 7 onto V2 and carrying it by a zygomatic branch into this area for your lacrimal gland, which remember your lacrimal gland seems like it would be controlled from up here. The lacrimation is actually controlled by facial nerve way over here. So if you think of all the facial expressions, one of them is sad. And what happens when you're sad? You cry. And so that's going to be your facial nerve that ends up controlling your lacrimal gland. So remember that. That's very important. It's one of the symptoms that your patients are going to present with if they have damage to that. So here we are, maxillary nerve comes out of foramen rotundum and comes down and gives off your zygomatic nerve. This is for general sensory of your cheekbone. You have infraorbital, which does sensory under your eye and the sides of your nose. Then we have some of the very not so important ones here, but just know that they generally do this sensory in this area. That's going to be your V2 branch. Okay, V2 is actually one of the most straightforward, but remember, let me put in 7 for you. The greater petrosal, synapses, pterygopalatine ganglion hops onto V2, your maxillary, then goes via zygomatic sensory branch, hops off and communicating, goes up to that lacrimal gland to create tears. Okay, just to remind you of that. So now let's go down to V3. So this guy I'm going to spend a little bit more time on because it's a little bit more important and they can pull up a lot more questions from this. This is a lot more high yield than those other two. However, let's go ahead and get into this. So V3, also known as your mandibular nerve or your mandibular branch, is very important. So we need to understand where this sensory is. So it's going to be the anterior portion of your ear, in front of your ear, the sides of your head, other than the top of your head and the just behind your eye on the side of your face, more like a posterior aspect above your ear. And it also does a lot of your mandible, almost all of your mandible except for the angle. The angle is actually here. So don't get confused by this picture. They should have drawn that in. But this is your angle of your mandible is here. It doesn't do sensory at that. That's going to be from your cervical plexus. But it does come down here. It does your chin, it does your nerve, and it does the buccal part of your mouth. So if you puff out your cheeks, it's going to do sensory where those puffed out parts on your cheeks are. But we'll talk about that. That's one of the tricks here. All right. So in our V3 branch, this is very important because it's not only sensory, it's also motor. So what I'm going to do, I'm going to address motor first. So motor travels along with your V3 branch. It goes out foramen ovale. So if you guys remember our mnemonic for foramen ovale, it literally spells out ovale, O-V-A-L-E. So O stands for the whole name, ovale, okay? V stands for your V3, your mandibular nerve, okay? A stands for accessory meningeal artery. That is a branch off your maxillary artery that goes up into your skull to serve blood supply to your meninges. It's very low yield, but that's just the A. It helps you to remember this. L is a very important nerve. You have to remember this. This is so high yield because it's weird. This is this guy right here. The L in ovale is for lesser petrosal because it hops onto your V3 branch. It's parasympathetics. Hops onto your V3 before it exits. Then those nerves exit out of foramen ovale. Then it hops off onto your otic ganglion, synapses to go out to control your parotid gland. So if you have damage of foramen ovale, you're going to lose general sensory of your lower jaw, everything but your angle of your mandible. You're going to lose sensory to your lower teeth. You're going to lose sensory to your lower lip. You're going to lose sensory to your tongue. You're going to lose a lot of different sensories, okay? You're going to lose sensory to your cheek. That's one. Okay, that's very important. Then you're going to lose motor, which we will describe in just a second. And also you will have presentation of dry mouth. So that's where that lesser petrosal comes in important. E is emissary vein. So you learned about different veins, how it goes, they go across the skull or not. The ones that go across the skull are known as emissary veins, and that also travels through here. So just remember, out of your ovale, the two things that are most important are your V3 branch and your lesser petrosal, and less high yield are your accessory meningeal and emissary veins. But the V and L are super important. And I will put this up on there so you can see it. So carrying down with the motor, once we exit out of the skull, we're kind of in the inner lower part, kind of behind, in front of your ear, okay? So this is kind of important because we give off two things. So remember your mast mat? So your mast is really, it's kind of stupid how they write this out. It literally stands for the word mastication. So all your chewing muscles, which we'll get to in just a second. But your mat, these are very important. Your mat is actually a mnemonic. It's M-A-T-T, or 4 different muscles. Your mast is a whole cluster of muscles. They don't actually stand for M-A-S-T, which is stupid. But your M-A-T-T, your mat, stands for nerve to mylohyoid, anterior belly digastric, which comes off your mylohyoid, right? These are the two muscles that it controls. Your tensor tympani and your tensor veli palatini. So remember, we learned about some of the different portions of your levators, right? So you have these stupid levators, and you're like, what is this levator veli palatini and tensor veli palatini? I keep getting confused at what nerve controls this. Trick is, if you have tensor, starts with a T. When in doubt, T's go with T's. So that is your trigeminal V3 branch. Tensor are your trigeminals. So that's your mat. Those are your two T's of your mat. So what do these muscles do? Tensor tympani. So this is someone that is going to have a clinical presentation of hyperacusis if you damage this nerve. Why? Because tensor tympani goes to your ear, and it contracts a muscle to tighten up your tympanic membrane. So this guy right here, I know it doesn't show it very well, but it actually comes over here and controls this, and it tightens it up. So if you have very loud sound, like you're at a very loud concert or something like that, it's moving your tympanic membrane a lot. And what happens when you move it a lot? It could rupture. So what do you do instead? You contract this muscle, and it kind of stiffens it like a board. So the sound waves aren't moving it and flapping it a lot, enabling a possibility of breaking it. Instead, it keeps it stiff and sturdy so that the sound doesn't damage your tympanic membrane. So that's what this muscle does. It's controlled by your trigeminal tensor tympani. So the symptom with this, if you damage, is known as hyperacusis. So they're very sensitive to loud noises. So keep that in mind when they describe a patient. Oh, they come in and it's real, like even the simplest communication is very loud for them. You're thinking of this nerve, mandibular V3 branch. Now, tensor veli palatini really just helps you swallow. So what it does is it tenses your soft palate, so then you can lift it up. Just think of, they kind of describe this as a soldier that's down. He's been shot, he's down, you got to carry him to the chopper. Get to the chopper, you know. And so this is the aspect of where you need to stiffen. He needs to flex his muscles best as he can, stiffen himself, so when you pick him up, it's easy. You can carry him to the chopper, set him down, and then do whatever. However, you need to tense it before you lift it. So tensor veli palatini, your trigeminal, allows you to tense your soft palate, and then your levator, V for Vegas, levator veli palatini, lifts it. So if you have problems with this, if you damage this nerve, you're going to have kind of this soggy palate. And if you have a soggy palate and you're trying to swallow, you're going to have trouble swallowing. So simply a patient comes in, has trouble swallowing, you need to do a little bit of investigation because this might be the nerve that's damaged. Of course, there's a lot. Could be your tongue, could be all these different things. But if they're talking about, oh, they have trouble chewing and they have problems swallowing, you're talking about trigeminal is the one that's most likely damaged here, as opposed to any of the others, okay? So keep that in mind. That's definitely a key words that come up for that. So let's talk about your mast of those mast mat. So your mast, M-A-S-T, is actually no mnemonic at all. It just stands for mastication. And if you don't know what mastication and you're hearing this word and you're going, is he using inappropriate language? It just means chewing. And so mastication is very important for your ability to eat, obviously. So here we are. So we have a few muscles that are involved in your mastication. So you have your masseter, which is your big bulky muscle. That's going to be a very strong one that allows you to bite down. You have your deep temporal and your lateral pterygoid, and lastly your medial pterygoid. So these are your mastication muscles. So the most important one is to understand what these do. Medial pterygoid, masseter, and deep temporal all close your mouth. So let's repeat that again. Medial pterygoid, masseter, and deep temporal all close your mouth. So they're chewing. However, in order to open your mouth, you have to have your lateral pterygoid. So that's going to be this guy right here. That controls a muscle that opens your mouth. It's the only muscle that opens your mouth for chewing. Okay? Keep that in mind. If you damage this nerve specifically, which is entirely rare, so rare that the anatomy department would put it on your test. So remember, your lateral pterygoid is the only one that opens, okay? And it's also in grays too. You'll probably see that a lot, but that's very important, okay? If you don't let this control opening your mouth at the same time as you kind of contract these other ones, it will dislocate your mandibular angle, or your joint, your TMJ. So that, again, if you have a spasm in your lateral pterygoid and you can't open your mouth and you don't relax that muscle and you try to utilize any of these three other ones, you're really going to be having problems because you're going to take apart that joint. Lastly, let's show your mylohyoid and your anterior belly digastric. So those are your M and A of your mat, mast mat, M-A, and that comes off down here. All right, so let's do a little bit of sensory. We're going to do this real quick. So mandibular sensory, again, I showed you that picture. If you didn't see that, go back to when I started this branch. Again, sensory fibers come out with this nerve, and it controls a few things. It pops off auriculotemporal, which is a nice little highway or side road into the neighborhood for parasympathetics, postganglionic parasympathetics for your parotid gland. Keep that in mind. This is high yield right here, auriculotemporal. It also does sensory, which is what the trigeminal portion of this does sensory. Remember, parasympathetics from cranial nerve 9 is what does the parotid gland, but sensory over this area is trigeminal, auriculotemporal. We're just going to give off this branch. Don't worry about this word long. Just remember this is your buccal nerve. All right, keywords here. Buccal nerve. Nerve is sensory. Anything that has nerve is sensory. If it has the same name and it says branch, that's your facial nerve. So let's put in that facial so you can definitely see what I'm talking about. 7. Here we go. Oh, what do you know? Buccal. I want you to, if you printed this, I want you to scratch out this N and put branch. I want you to put branch on all 5 of these. This is so important that you label these branches and not nerves, because buccal nerve is sensory, buccal branch is motor for your buccinator, and that's like if you have problems with that, then you're going to have drooling. That's that guy. And then you go, oh, what's this? Zygomatic. Wait, I saw zygomatic all the way up here. Shoot, I can't differentiate them. Remember, these 5 are branches, and they will specifically write branch. So if you see zygomatic branch and zygomatic nerve as options, remember, zygomatic branch is for your facial. Zygomatic nerve is sensory under your eye, or pretty much your cheekbone, okay? And that's from your V2. I want you guys to definitely recognize that. That's very, they for some reason love to trick you on that. So keep that in mind. Most importantly, here we come down here further. Let's continue this. This is this area right here is so high yield. So high yield. If we damage it in different parts of these, you're going to have with different presentations. So I'm going to go over this really quickly, okay? And remember this area as they can label different things for your lab as well, especially your chorda tympani. I almost can guarantee you that's going to be on the test because it's tiny, small, and it's really cool. It's usually never injured in patients, but anatomists seem to think that it is. So we have our branch of our V3 comes down sensory, and we know that it's going to do the anterior 2/3 touch. And so if I tickle your tongue at the tip, it's your trigeminal. Let me emphasize those T's again. If I tickle the tip of your tongue, it's trigeminal. That's your anterior 2/3, okay? I'm gonna, if you didn't get that, just do a little rewind, and you should definitely have that down. So tickling is just general sensory. That's going to be where this dark blue comes down here. Remember, your special sensory actually comes from your chorda tympani for taste, and that is from cranial nerve number 7. Okay? If you didn't get that, go to my cranial nerve 7 video, and you'll definitely get that information. So right here, if I damage before the lingual nerve fusion, or before chorda tympani fuses with lingual nerve, then I'm just going to lose everything having to do with the trigeminal at this aspect, right? So at this part right here, we give off inferior alveolar. So this does all your sensory of your lower teeth, your lower lip, and your jaw. Or I'm sorry, yeah, most of your jaw, your lower jaw, and your chin. So that's where inferior alveolar kind of comes in. Alveolar just means teeth. So superior alveolar is from V2 branch. That does your upper teeth. Inferior alveolar is your lower teeth, and that's where those guys come from. Mental, the mentis is actually just your chin, is what the name of that is. So your mental nerve there. However, if I damage before the branching of inferior alveolar and just simply that. If I damage it here, right here, before any of these guys, we'll lose muscle innervation for mylohyoid, anterior belly digastric. You will lose inferior alveolar sensory of your jaw, your chin, your lower teeth. You also will lose sensory of your anterior 2/3 of your tongue. That's it. That's all you lose, because that's what we're losing right here. However, if it's after mylohyoid, but before inferior alveolar, then the motor's fine, but I'll lose anterior 2/3 tongue touch, and all this lower jaw and lower teeth and your lower lip and stuff like that, sensory. However, if I damage it after inferior alveolar, so now this part, so now I have sensory just fine here, but all I lose is, I'm going to lose touch, vibration, proprioception of your tongue. We don't usually do most of the test on your tongue, that's kind of ridiculous, but that's what you'll lose if you do it after inferior alveolar and before chorda tympani comes in. Now, if I do the lingual nerve, if I damage the lingual nerve after the fusion of chorda tympani, now I'm going to lose a lot. The lingual nerve after fusion of inferior alveolar, why do I keep saying that? After the fusion of lingual nerve and chorda tympani, but before submandibular ganglion, that's this guy. There's a lot of lesions here, so practice this over and over and over and say what symptoms you're going to damage. If you haven't done this already, this is very high yield. This is on our test, it was 6 to 7 questions were straight from this area. That's why I'm emphasizing this point. So let me repeat this again. Lingual nerve, branch off of V3 branch. After fusion of chorda tympani and before submandibular, that means I'm going to lose all 4 of these, well, all 3 of these fibers really. I'm going to lose taste on the anterior 2/3, touch on the anterior 2/3, and I will have dry mouth. Innervation of some lingual and submandibular glands. Now, if it's singly, if they just say lingual nerve this is where the lesion is talking about. If it just says damage to the lingual nerve, and they're not describing after or before or anything like this, it's here. Okay? This is a trick. Lingual nerve only. They could say after sublingual or submandibular ganglion, but just think of it as a lingual nerve. If you just damage just the lingual nerve and no other information is given, what you'll lose is taste and touch, general sensory, on the anterior 2/3. How's the patient going to present? Oh, I can't taste anything on the anterior 2/3 of my tongue. I can't feel anything on the anterior 2/3 of my tongue. Where's the lesion? If that's the only presentation of this patient, just those two right here, after submandibular, after this, yeah, everything is just right here, okay? Super high yield. All right, so that pretty much completes the 3 branches of your trigeminal. Again, if you have any questions, go to our Facebook and post questions there. Usually we don't answer them on our YouTube page, but you can definitely get the link to this website if you haven't been utilizing it. It is very, very helpful. It looks kind of confusing with all these nerves, but it's nice because I can just put in trigeminal and it looks like that guy. And it's not too complicated. So definitely check out our Facebook page, like us, and subscribe. And definitely check out also our neuroanatomy videos because we'll go over some high yield stuff for you as well.